picture like this, and you need to identify the muscles labeled A to F. So A, B, C, D, E, F. So this you can identify easily the muscle starting from the mastoid process to the sternum, sternocleidomastoid. So B you can easily identify. This one is trapezius. Then C is this is the omohyoid posterior median. So there has to be anterior radius. Then D is a muscle levator scapulae. So the D muscle is levator scapulae, and then you get a E is a masseter. This one is masseter. Then what are the different nerves G to H? So this G nerve is the Erb's point going towards the ear, lobule, greater auricular nerve. This one is going towards trapezius. So it's axis nerve GH, and arteries level IJKL, I to L. So this one is external carotid artery, you see outside. And J is a maxillary artery or facial artery, and this is maxillary artery, and L is superficial temporal artery. So how is the arrangement of deep fascia? There is investing layer, then prevertebral, pretracheal, carotid. These are the different layers. So boundaries of posterior triangle. So you get trapezius behind, clavicle between, and this is the sternomastoid. So these are the boundaries of posterior triangle. Then what are the actions of sternocleidomastoid? It turns to the opposite side and shrugging the shoulder. Structure found in the posterior triangle. You find so many structures in the posterior triangle. These are maybe the nerves, the Erb's point, spinal axis, cervical, brachial plexus, arteries, subclavian artery. So here is the nerves, the arteries can be here, subclavian artery, suprascapular and occipital arteries. These are the vessels, external jugular vein, starting from here and like this, and the lymph nodes. What would be the effect of damage to spinal axis and nerve? And that causes paralysis of trapezius and shrugging of shoulder and turning. What is surface marking of accessory nerve? Now, accessory nerve. So, atlas word of the trapezius. So you see, this is the trapezius. The question is surface marking. This is the question. Transverse process of atlas to the anterior border of trapezius 5 cm above the clavicle. So there is a clavicle, you just measure 5 cm above, and then 5 cm above, and anterior transverse process of atlas to the anterior border of trapezius. So trapezius, so here this is the axis now. Boundaries of anterior triangle of neck. So you see, this is the anterior triangle of the neck. So anterior triangle is submental, superior lower part of mandible. This is the lower part of mandible. posteriorly by the sternocleidomastoid, lower part of mandible, and midline of the neck. Anterior is divided into, then there is submandibular, submental, this is submental, submandibular, and the another is carotid and muscular triangles. So this one is the carotid triangle, here external, and this one is muscular triangle. So these are the triangles. Submental is avoided by the anterior digastric, and mandible, posterior digastric. Muscular triangle is bounded by sternomastoid and all that. So you get this station showing the dissection having, if you see the nerves. So first of all, what you see is this one is the ear, the cut part of the ear. So ear like this, so that lower part is cut. This is the nose, this is the mouth, this is the chin, and this is the neck. So here are the nerves from here. So this is the facial nerve, one branch going up, temporal branch, then you get a zygomatic, you get a buccal branch, and you get a mandibular branch. Then there is a cervical branch, it's not clear, but this can be a cervical branch. So these are the nerves of the facial nerve. 5 branches, 1, 2, 3, 4, 5. So these are 5 branches of facial nerve. Each has got a significance, temporal for raising supply to the muscles here. Then margin mandibular, it supplies the angle of mouth, asymmetry, symmetry. Then you can see this is an artery. This can be external carotid artery. This one is one artery branch. It can be the lingual artery, and this is another artery. It is facial artery. So this is lingual going to the tongue. This is facial. If you see, then the anterior branches of, then it goes here somewhere, it has to be some maxillary artery. Then again it has superior thyroid, has to be here only. This is superior thyroid going down, posterior occipital. So this external carotid artery. And then what you see, the muscles. So this is again the larger artery, superficial temporal from the external carotid, and this one will be the deep internal carotid going inside. So what does level A is? The facial artery originates from external carotid artery. Level B is marginal mandibular nerve, containing asymmetral mesentery. Level C is temporal branch. So tip of the bony structure is crossing the tip of the arrow. What is the clinical consequences? Elevation of the eyebrow. So difficult to eyebrow. So facial nerve, you see the facial nerve pons and medulla, it comes from inside. So this stylomastoid and all that, and then if you see, so it's like this. There is one PGP, greater petrosal, to the lacrimal gland. So lacrimal gland, then you get a nerve to stapedius, to the nerve to stapedius for the ear, then the nerve chorda tympani to the tongue, then you get, it comes out, here the scissor nerve comes out and leads into many nerves. What are the branches of supply? What do you quickly test the motor function or division of the facial nerve? So eyebrow, closing the eyes, closing the mouth, showing the teeth, and tense 5. Surface marking of the parotid gland. Parotid gland, the location of the parotid, it's far from the tragus of the ear, angle of the mandible, below here, goes up to the mastoid. This is the parotid triangle. Then where does parotid duct open? If you see upper second molar tooth, it starts from here and it is upper second molar tooth. Which nerve runs close parallel to parotid gland? So the commonly this nerve which is passing very close is the buccal branch of the facial nerve runs along the parotid duct in patient cut and laceration cheek or salt. This is very important nerve, that is the buccal branch. What is the clinical signal of this patient in facial trauma? So what happens whenever there is trauma to the face, that nerve can get a laceration of parotid duct can be excluded by examining the papilla for signs of bleeding or bruising. The duct can be gently cannulated lacrimal probe.
So let's go for this station. This is the ear, the picture of the ear and different parts of the ear. So everyone will remember this is like a helix. So if you see this as a helix, opposite is anti-helix. Helix, anti-helix. So two parts. This is tragus and this is antitragus. Tragus, antitragus. Tragus, antitragus. Helix, antihelix. So this is antihelix. So this is superior crus, inferior crus. So three structures are just like everyone knows. This is ear lobule. Now concha, this is concave shape, it's the concha, and this is elevated part, so scapha. This is superior, inferior, scapha, concha. Now you see there is some triangular fossa. He is a triangular fossa. So identify different parts. What is sensory nerve supply to the ear? So ear has got more than around 6 nerves. Greater auricular nerve, basically ear lobule, lesser occipital, auriculotemporal, vagus or Arnold's nerve, facial nerve, and glossopharyngeal or Jacobson's nerve. What is the clinical significance pattern of this nerve supply? So a clinical significant consequence of this pattern is that pathology from different sites can refer pain to the ear. The ear receives sensory supply from 4 cranial nerves: trigeminal, facial, glossopharyngeal, and vagus, and 2 spinal nerves, C2, C3. So vagus is there, auriculotemporal is branch of trigeminal, lesser occipital is from C2, 3, and greater auricular. Then these are the different nerves. So cranial nerve, trigeminal, facial, glossopharyngeal, vagus, and spinal. Referred otology can be due to trigeminal neuralgia, pathology of molar tooth, parotid gland, temporomandibular joint. It can be oropharynx, laryngopharynx, esophagus. Any chronic ear pain with normal ear examination must be assumed that there is occult inside malignancy. So this is the significance. So sensory branches. What are sensory branches of cervical plexus? Lesser occipital, greater auricular, supraclavicular, and transverse cervical. These are the 4 nerves. Sensory dermatomes that correspond to cervical plexus. So it is C1 to C4. So the brachial plexus C5 before that. C1 has no sensory, the spinal contributes follows. Lesser occipital C2, C3, greater auricular C3, C4, transverse cervical C3, C2, C3, and supraclavicular C3, 4. Dermatome, sensory dermatome that correspond to cervical plexus are C1 dermatome, superior posterior of the scalp is C2, posterior side superior, upper neck and behind the ear is C3, and lower neck to the clavicle is C4. What is the name of point that cervical plexus emerged to the prevertebral fissure? That is the Erb's point. What is the surface marking of this point? Midpoint of posterior border of sternocleidomastoid, most commonly. Thus, this point has clinical use because this has got so many nerves. So exit nerve must be identified and preserved, and there are cervical plexus. So this one is another station surface marking of the following parts. So now what you see here is the central this thyroid cartilage, or you call this as Adam's apple. Above that there is hyoid, thyroid, and cricoid. So it goes like this. So surface marking of the hyoid, thyroid, cricoid. Then below is the first trickle ring, thyroid membrane. So thyroid membrane, laryngeal prominence is also called as thyroid, cricothyroid. In between the cricoid and thyroid, this is cricothyroid, where the puncture is done. These are the layers that would cut through the tracheostomy. So this is commonly asked question. Skin, subcutaneous tissue, you would cut the platysma, then investing layer of deep fascia, then you cut the strap muscles and pretracheal layer. That is important. What are strap muscles? So suprahyoid strap muscle known as infrahyoid muscles. So generally strap muscles are infrahyoid, TOSS, thyroid, omoid, sternothyroid, sternohyoid. So their attachments are, so if it is hyoid above, thyroid between, and sternum is down. So sternothyroid, thyroid, and sternohyoid is above. Thyroid and omohyoid is just below. So what are the muscles attachments? What is their actions? They cause elevation of the thyroid, so elevation of the larynx during deglutition and all that. Lying lateral to the sternothyroid is sternohyoid. So what is the motor nerve supply? Sixth question. The motor nerve supply is from muscles is supplied by C1 fiber from cervical plexus. So these are the motor nerve supplies. What is the blood supply to the sternal strap muscles? Strap muscles supply inferior and superior thyroid arteries, superior thyroid artery and inferior thyroid artery. What is omohyoid useful landform performing selective neck dissection? Omohyoid useful landform performs selective neck dissection. For example, it marks the neck dissection of the tongue and squamous cell carcinoma with no evidence of metastasis. It is standard practice to dissect only level 1, 2, 3 of the neck, as there are most levels of the tongue metastasis. Supraomohyoid neck dissection. 7 cervical vertebra. 7 cervical vertebra surface marking. So actually these are done in the manner of C1, C2, C3, C4, C5, C6, C7. So each has got a level. C1 is at the level of hard palate, it's very deep, and C2 is angle of mandible. So when there is angle of mandible, C3 is hyoid, H, thyroid, and cricoid. So this is thyroid cartilage, this is suprathyroid notch, and C7 is upper tracheal rings. So this one is another stem where you can see this is angiography. So this here you see this is internal carotid and this is external carotid. So first branch is superior thyroid artery, then there is a lingual artery, then there is a facial artery which has got tortuous. So these are the three: superior thyroid first, lingual, facial. Then when it goes inside, this one is maxillary artery, which is a very long branch. So from here there can be a middle meningeal artery. So sixth one, this is the middle meningeal artery which goes deep. Then this one is superficial temporal artery. This is going inside. And now posteriorly you can see ascending pharyngeal artery, and 10th is occipital artery. This is occipital, this ascending pharyngeal ascending. Now this is internal carotid artery. It has got, when you go inside internal carotid artery, then it goes inside and forms the middle cerebral and anterior cerebral. That's why this is anterior cerebral, middle cerebral. Branches of external carotid artery. List the branches of internal carotid artery in neck. Actually, neck has got no. So, external carotid artery has got anterior branches, ascending pharyngeal, lingual, facial, and posterior auricular, occipital, and then there is maxillary, superficial temporal, superior thyroid. Cavernous sinus divides into anterior and middle cerebral artery and gives a small proclamation. So internal carotid artery, wet cervical level corresponds to bifurcation is C4 level. Branches of maxillary artery. Again, this is a very long artery and has got many branches. So maxillary artery divides into three parts. If you see, this is maxillary artery. So it has got three parts. The first part inferior to lateral pterygoid. So there is a lateral pterygoid, muscle, inferior pterygoid. First part, five branches. Second part, so middle meningeal is a branch of first part and it is one of the five branches. Auricular branches, deep auricular, tympanic, anterior tympanic, accessory meningeal and inferior alveolar. Second part behind the lateral pterygoid. So behind lateral pterygoid, four branches: deep temporal, pterygoid artery, masseteric artery, and buccal artery. And third part, superior. So lateral pterygoid is like this, below, behind, and superior. So superior to lateral pterygoid, there are again six branches. So 5, 4, and 6. Alveolar, infraorbital, descending palatine, artery to pterygoid canal. So, what are the nerves at risk during surgery? To carotid artery. When you are doing surgery on the carotid artery, so here's the carotid artery, the nerves 9, 10th, 11th basically. Biggest 10th, ansa cervicalis, hypoglossal 12th, 10th, 11th, 12th. Sensory branch of cervical branch, glossopharyngeal, marginal branch of facial nerve. Whereas vertebral artery is a branch of arch of aorta, two vertebral joint to become basilar artery, branch of first part of subclavian artery, thyrocervical artery, first part of subclavian artery. Course of arteries ascends in the neck. The paid artery is longest colon and ascends into the foramen of transverse process, upper sixth vertebral and across the posterior arch and enters to the skull to foramen magnum. How does vertebral artery terminate? They join each other to form the basilar artery, epinomnium anastomosis of the artery, circle of Willis, subclavian steal syndrome. It happens whenever there is obstruction to the flow from before the origin of vertebral artery. Subclavian steal is found in the initial finding. 2% of the cases, patient gets syncopal attack because the blood flow from the brain is stolen towards the arm. So this one is the facial. Just the question is layers of the scalp and as skin, subconnective tissue, loose alveolar tissue, aponeurosis, periosteum. Blood supply and where do the vessels originate? So scalp has got the blood supply supratrochlear from above. So this is superficial temporal, two arteries like these, posterior auricular and occipital, and supratrochlear and supraorbital. So 2 from the internal carotid, 3 from the external carotid. This is anastomosis. The supraorbital artery supratrochlear exists through the scalp supratrochlear foramen. So from here supratrochlear foramen, the artery goes above. Superficial temporal artery lies lateral, posterior auricular lies behind the ear and posterior vessels. Path of the vessels on the scalp: supratrochlear, supraorbital, superficial temporal, anterior and posterior branches, posterior auricular and occipital. In which layer of the scalp do the blood vessels? So deep connective tissue, second layer. Why do scalp laceration profuse? Because this is thick below the skin layer has contains hair follicles. So vessels is attached firmly to fibrous tissue and they doesn't contract. How do they control in trauma setting pressure and suturing the scalp? In which layer flaps raise in the scalp? Loose connective tissue. What is the venous drainage? The venous drainage scalp flows the arteries of the same name. Does the pattern of veins has clinical significance? This clinical significance, what is the pattern of the venous drainage has rare potential to spread to infection from scalp dip-like veins, from the scalp dip-like veins below the periosteum, so causing osteomyelitis. Which nerve supplies sensation to the scalp? Now the scalp has got zygomatico-frontal, trigeminal, greater occipital, lesser occipital, auriculotemporal, supraorbital, supratrochlear. So orbital, zygomatico, and two occipital, auriculotemporal. So this is a picture which is showing that this is submandibular gland, cielogram, and it's opening into of the duct into the frenulum of the tongue. Submandibular gland, cielogram. What are the structures labeled A and B? A is the submandibular gland and B is the Wharton's duct or submandibular duct. Standard incision made for the submandibular gland. Incision is this, if suppose this is the mandible 3 centimeter below and parallel to the mandible. Why it is made? To avoid marginal mandibular nerve, because marginal mandibular nerve is going here. So avoid that. Then in what anatomical triangle does mandibular gland lie? This is a triangle, submandibular triangle. It's also called lies digastric or submandibular triangle. What nerve will damage submandibular gland? Excision. So there are many nerves, falling nerves. It can be lingual nerve, it can be the nerve to mylohyoid, nerve to the hypoglossal nerve, or marginal mandibular nerve. Which vessels are usually encountered during the approach to submandibular gland? Facial nerve and the vein. So artery and the artery is like this, and then vein is there. These are the two things. The, which muscle separates the submandibular gland? So it is having like this. There is a mylohyoid muscle in between, superficial in the deep. What are the attachments of nerve supply of this muscle? Trigeminal nerve. Why do submandibular gland open in the back beneath the tongue, frenulum of the tongue? What is the nerve supply of submandibular gland? Actually, it is coded with many parasympathetic supply. Compare the acini of parotid, lingual, and submandibular. It has got serous and mucus submandibular. So that's why the stones are common, because viscous, alkaline, sloping, and serous and mucus. So this one is another station which is showing the sagittal section having many parts. This one is the tongue, this is one is the mandible, this one is the palate, here is the nose. So this one is the nasopharynx, this is oropharynx, and then this is the larynx, and you get it as here is the hyoid bone. So this one is epiglottis, this is larynx, and this one is the esophagus. So larynx is anterior, esophagus posterior, this is the vertebrae, and here are the vertebrae like this. You can see the cervical vertebrae 1, 2, 3, 4, 5, 6, 7. So these are the 7 cervical vertebrae. So you can see the spine is like this and a lot of muscles. So this is the neck, and you see the brain is sitting here, and this is the spinal cord, and the brain, the falx cerebri, tentorium cerebelli. This is the anterior, this is the middle cranial, posterior cranial fossa. So this is going down. Then you see these are the sinuses, sphenoid bone, and here is the nasal cavity and concha. So what you see inferior concha, middle concha, and the superior concha. So openings, there are different openings. Frontal sinus, ethmoidal sinus, sphenoidal sinus. Now what you see, name the structures A to N. So what is A? This one is the middle concus. This one is the inferior concus. And where is the superior? This one inferior, middle, superior. So three concha are like this. Then where is so A is the middle concus, and B is the, this is the pituitary. This has to be the pituitary gland because pituitary fossa is like this. And C structure C is here. It has to be transverse. This is sinus. So this is the transverse sinus. And then D again. Where is D? This is the falx cerebri. And E is definitely a tongue. F is the inferior concus. G is the G. This one is ethmoidal sinus. And where is H? H1 is the superior conchi. Then I is, this one is epiglottis. J, this one is esophagus. K is the mandible. Then there is M. M is the frontal side. O is a sphenoidal. Superior meatus. Middle sinus, then there is superior meatus. Then P is middle meatus. And Q is inferior meatus. So below the concus there will be meatus, middle concha, middle meatus, superior concha, superior meatus. So these are openings: superior, middle, and inferior. So what are the different openings? Then R and S. S is the opening into the ear, that is eustachian tube. So structures from O to S. What difference? What do structures O to S communicate? Now O to S. Superior meatus lies between superior and middle concha and communicates with ethmoidal sinus. Superior meatus, ethmoidal sinus. Middle meatus lies between frontal sinus, ethmoidal sinus. Inferior meatus. So pharynx can be divided into the three parts: nasopharynx, oesopharynx, and laryngopharynx. The arrangement of the pharyngeal muscles. So there is superior constrictor, middle constrictor, inferior constrictor, whose upper fibers are called as thyropharynges and lower fibers are cricopharynges. What is the motor innervation of all from the vagus and accessory nerve except stylopharynges, which is supplied by glossopharyngeal nerve? So muscles of the palate are what are the motor inertia? Then describe the muscles of palate. So these are villi palati, tensor and levator, palatoglossus pharyngeus, and uvula. So these are the five muscles. What is motor innervation of palatal muscles? So tensor villi palati from trigeminal nerve and palatoglossus vagus plus accessory nerve. So this one is another stem. You see the transverse section. Now this is difficult to identify. Sometimes what happens, This is the nasal cavity you can identify. Oh, sorry. K is this the ear, this is the spine. So this is not nasal cavity. This is the level of this is ear is completely seen, which is below. The spine is seen. Nasal cavity you cannot see the spine. It has to be the brain. So spine is seen means it's at the level of vertebra, spinal cord, and neck, and everything is seen. So this can be C can be the vein interjugular. So what you see, this is the spine, and these are muscles behind the spine. So neck muscles, and this is at the level of neck. A, this one is trapezius. Then what you see, this is sternocleidomastoid. B, and this one is internal jugular vein, and D is the carotid artery. Then has to be a vagus nerve. So this is the carotid sheath. This one is another carotid sheath, two carotid sheaths. So this is the neck, and this is the larynx. And L1 is this is pharynx, this is larynx. Esophagus is compressed, and then this one is thyroid like this, and this is platysma. What vertebral level? This has to be C4-5 because our carotid artery is not bifurcated. Single carotid artery is there. Then you see it is C4-5. To which vertebral does the isthmus of thyroid corresponds? Isthmus is corresponding to isthmus C4 level. Thyroid gland and the layers of the cervical fascia. So relationship of the thyroid gland is lies in the pretracheal fascia and surround the larynx and esophagus. Blood supply of the thyroid superior. So if this is the thyroid gland, it has got superior thyroid artery, inferior thyroid artery, and middle. The superior is from the external carotid artery. This is thyrocervical trunk, and sometimes inferior thyroidema artery. A risk of damage during this thyroidectomy is the recurrent laryngeal nerve. What is consequence? There is different voice, hoarseness of voice, difficulty in breathing, and stridor, and more many unilateral, bilateral paralysis. Venous drainage. So venous drainage has got superior, middle, and inferior. Again, all go to the interjugular vein. So, what are parathyroid glands? Where parathyroid glands are found? So, parathyroid glands are found each side are usually deep and posterior to the thyroid gland. So, there are two superior, two inferior. What is the blood supply venous ratio parathyroid? Inferior thyroid artery. It supplies it. So, this is another picture of a. You see, this one is epiglottis, and then there is vallecula and array epiglottic fold. So this space is vallecula, and B is on the sides array epiglottic fold, and this anterior is piriform fossa. Then here you can see the vocal cords, posterior cricothyroid. Orient the specimen. So epiglottis superior arising from the anterior surface, tracheal ring inferior specimen viewed from the incise posterior sides. Now name the fossa marked with the blue triangle D. So this is piriform fossa. What is the significance of this piriform fossa? The bonded medially by epiglottic and E is the posterior arytenoid ligament. What is muscle E so unique? E muscle is, so this is like this, abductor of the vocal cords. Identify the muscle E. E is cricoarytenoid. Cricoarytenoid. Describe the nerve supply of all muscles of the larynx. Recurrent laryngeal nerve except external larynx. Cricopharynx, which is supplied by cricothyroid muscle, which is by external laryngeal. Crico is by external laryngeal. Describe likely position of swallowed fish bone. So it can be in the vallecula or the piriform fossa. What membrane? F. So there is a membrane which is that F. This is the cricothyroid. This is the cricoid. This is the thyroid. So this membrane is the F. Clinical relevance is cricothyrectomy, surface marking of the point. Laryngoscopy, function of the twofold G and H. So G and H. So this one is G and this is H. G is the vestibular cord, they have minimal role in phonation. H is the vocal cords. So these are the vocal cords. This is important. It has to be open while you put the. Now this is the face. You get the muscles, orbicularis oris, levator angle, levator labia superioris, zygomaticus minor, zygomaticus major. This is the facial artery. So facial artery, zygomaticus major, zygomaticus minor, levator superioris, levator ala nasi. So nasal bone ala nasal, and this is the organ. G is facial artery. So what is the name of structure G as it ascends in the face? Angular artery. What is the nerve supply to the muscles of facial expression is facial nerve. Nerve supply deep to the muscles. Nerves lie deep or superficial muscles. So they deep. Muscles are supplied to marginal mandible branch of the nerve. Deep angular, deep levalis mentalis. What is the clinical significant injury to this branch? So what you do, injury to the knee to depressor, lower lip and angle of the mouth. What is the clinical picture here? What is the facial muscle causes vertical and horizontal wrinkles in the glabella, coraculus speculi and processes? What is knowledge of anatomy important to plastic surgeons for injection of botulinum toxins? What is Bell's palsy, mononuclear facial nerve palsy? Functional problem associated with the condition. So it can be loss of facial animation, loss of blinking, closure ipsilateral panel, drooling of the saliva.